Over to you.
Thank you for the candid introduction. Good afternoon, ladies and gentlemen, and professors. So it's my great pleasure to be here to join this time fantastic congress of AFSUMB. So I will talk about some experience for the differential diagnosis of lymph node with ultra-resolution microscopy. So lymph nodes, usually they are small, but sometimes they can bring big problems to clinical situations. So superficial lymph node enlargement are very, very common. Usually there are 4 different reasons for this type of enlargement. It could be reactive hypoplasia from the virus or some bacterial infection, or can be tumor, even metastasis or lymphoma, or maybe some specific infection, let's say tuberculosis. And also there are some other reasons for lymph node enlargement, let's say sarcoidosis or necrotizing lymphadenopathy. With ultrasound, to do some diagnosis for lymph node, we'll evaluate from grayscale the shape, the header structures, and the perinodular inflammation. These information can give us some diagnostic information. But what's more, as we all know, lymph node has a very specific vascular structures. The arteries go into the lymph node through the hilum with some tiny branches distributed within the lymph node. This kind of vessels are very typical. With color Doppler, we can evaluate its distribution, but general color Doppler is not very sensitivity. For sure, we are thinking about how about bubbles. With contrast enhanced ultrasound, we can see the profusion very clearly. And definitely, about 20 years ago, when the first appearance of bubbles into ultrasound field, Springer published 2 books, one in Italy, another one in Germany. The books talk about contrast enhancement ultrasound. Both books have chapters talking about lymph node, but unfortunately, from the books, the information from the books about lymph node enhancement is not very useful, especially for differential diagnosis for different lymph node. How about now? 20 years later, we have many different types of bubbles, and also the ultrasound technique made a big improvement. We'll see a case firstly. Both patients has an enlarged lymph node of the left inguinal region. From grayscale ultrasound, we cannot find the normal structure of the lymph node. Both are hypoechoic and without hilum. When we do contrast injection, we can see the bubbles come into the lymph node directly, and the whole lymph node enhanced very quickly. For sure, we can say there's no necrosis area within the lymph node, but can we tell the difference between the perfusion of these two nodes, can we tell which one is benign, which one is malignant? I think the answer is no. It's very hard. The biopsy result for the left patient is a reactive hyperplasia of the lymph node, but for the right patient, the diagnosis is metastasis from melanoma. So it's very hard. Why we cannot tell the microvascular structures? It's because from the physical point, there is a bottleneck, the diffraction limited, even with high frequency linear transducer. The resolution limit is around 90 to 100 micrometers. So we cannot use general ultrasound, conventional ultrasound, to describe microvessels within 10 micrometers. And also we cannot see the bubble itself because bubble is too small. How can we break the barrier? The new technology, ultra-resolution ultrasound, is a new technique. For this time, after contrast agent be injected into the body, we are not focusing on the bubble themselves. This time, we use ultra-fast plane wave imaging to track the bubble movement. We're imaging the trajectories of the bubbles, and after tracking the trajectory of the bubbles, we can draw the line of microvascular structures. It's a little similar to the cars in the bridge on the Han River in Danang City. We can see so many cars with lights on the bridge, but we cannot figure out which cars, the shape, and we cannot tell how many cars there. But if we just follow the lines from the cars, we can draw the line of the bridge. So that's a little bit similar to URM, how it works. The history of URM is not very long, just about 15 years. Until 2015, Tenter team from France, they published the paper in Nature. So from that time, there's many groups all over the world to do research study about URM. Until now, this technique transferred from the lab to the bed. We can use URM in the clinical cases right now. For the summary for URM, this super resolution ultrasound is an imaging technique that can assess functions such as microvascular location, structures, and blood flow velocities by tracking and localizing microbubbles, enable to image the blood vessel at a micron level. So before we do research with URM for lymph node, I would say something to pay attention. So either sonoville or sonozoid you can use for lymph node. Just pay attention to adjust mechanical index according to different bubbles. For the superficial lymph nodes, for sure, we select high frequency transducers and with small organ precise. pay attention to planes selections, especially when lymph node is very close to the artery. We should be avoid to minimize pulsation of artifacts. If the lymph node has a clear hilum, we use long axis view and included the hilum structure to be for the following examination. If the lymph node has not a clear hilum, we select the plane with the largest cross section or one section that reveals special features, let's say some hypoechoic point within the lymph node, as you can see here. Sometimes the lymph node is very large. We cannot capture the whole lymph node within ultrasound view. At this time, we select the partial long axis view of the lymph node and included its hilum, as you can see here. So this is very important for your URM images. During URM acquisition, patients are required to hold their breath, and also you should keep your transducer stationary. Before URM, we can use general color Doppler to find if the lymph node with hypovascularity or hyper. If there is no much flow within the lymph node, we can do URM acquisition just immediately after the bubble arrival. If there is hypovascularity of the lymph node, usually we will wait 20 seconds after bubble's arrival to avoid the peak of the bubble in the vessels. Here you can see a picture, images of normal lymph node. A grayscale shows the hilum, and contrast bubbles just enter the hilum here. With URM, there are several types to show this kind of image with direction of the bubbles, density of the bubbles, and the velocity of the bubbles to give you different information. From these four kinds of maps, we can have some parameters of the lymph node, let's say density, perfusion index, and complexity of the vessels. So here is a chart of our study. In 3 months, we do URM for 46 patients with 49 enlarged lymph nodes. All the lymph nodes can be separated in 3 groups: a reactive hypoplasia group, metastatic lymph node group, and lymphoma group. Among these groups, from the quantitative parameters, the max density has a significant difference among 3 groups. Even though we can see some interesting thing here, for the density, lymphoma group has a high level. That means usually a lymphoma will have hypervascularization in this condition. For the velocity, metastatic group has a high velocities compared to other groups. Let's see some cases. This female enlarged lymph node, but it's normal, or we can call that reactive hypoplasia. The grayscale shows the normal structure of this lymph node. After injection of bubbles, we can see quickly the enhancement of the lymph node, but it's very hard to tell the architecture of the vessels. But with URM, it's very easy. You can see all the bubbles, the trajectory of the bubbles within the lymph node is similar to normal structures. This case is lymphoma at different map, density, velocity, and curvature map of the lymphoma. For sure, it's totally different from the normal or even reactive hypoplasia lymph node. You cannot find where is the hilum and also the peripheral vessels around the lymph node. And here is another case. Let's see the video of the contrast firstly. Here is the lymph node, not that much, not that large. You see the bubble within the lymph node here. You cannot tell the difference within the lymph node. They look similar here, and here is not so much bubble within the lymph node. But with URM, it's very interesting. We can find this part. You see this part, the peripheral neurovascularization can be described by URM in this case. And also we can use some quantitative parameters to describe the level of the lymph node. Here we use the perfusion index for lymph node. It's very high compared to normal lymph node. And we can find the most part with high perfusion index area is here. And this map is a vascular curvature and also higher in lymphoma than in normal lymph node. You can see the number here, and this for just around 1.07 for the normal lymph node. The complexity of the lymphoma is also higher compared to normal lymph node. We can tell them not just from what you see. We can tell from the numbers to do the exactly comparison between different groups. What more can we get from URM? Let's see another case. These two ladies in the same age for the same diagnosis, lymphoma, but this lady just after treatment. And this lady at initial diagnosis for lymphoma. From grayscale, we can tell the lady with enlarged lymph node for the initial diagnosis. But both of them, the hilum is not very clearly. How about bubbles? You can see with contrast enhanced ultrasound, both lymph nodes enhanced very quickly. So from the contrast enhanced ultrasound, we cannot tell the difference between treatment and without treatment. No useful even compared to grayscale ultrasound. Can URM give us some more information? Let's see this case for comparison. The male, 7 years old, and another patient, 44 years old. This patient received 1 circle of chemotherapy, this patient at initial diagnosis. From URM, you can see how different of the microvascular structures within the lymph node. After one cycle of chemotherapy, this patient, the URM revealed reduction of the vessels. That means the treatment is effective. The patient can receive the second cycle for the chemotherapy. This case is a metastatic lymph node. Absolutely, from the grayscale ultrasound, we can say this is abnormal lymph node. With URM, we can find some interesting thing here. The peripheral vessels with a circumferential distribution and disorganized architecture here, we can see it's totally different from compared to normal lymph node and even lipoma. There is another case for metastatic lymph node, different type of maps, density and direction and velocity to show the peripheral neurovascularization formation here. This female, she had a breast cancer surgery before. During the follow-up, we found an enlarged lymph node in her axillary region. So URM can find the abnormal hypoperfused area here and hypoperfused region within the same lymph node. I think this information is useful for analysis of different type metastases and the situation of metastases, but we need more cases. For the summary, normal lymph node with URM, we can clearly delineate internal and peripheral microvascular architectures. For lymphoma, we can visualize peripheral neuroangiogenesis and identifies abnormal hyperfusion, provides some assessment of vessels disorganized and complexity, and monitors treatment from some parameters such as vascular density and complexity. For metastatic lymph node, we can describe perfusion difference, and also for the reactive one, it looks similar to the normal lymph node. So I think with URM, we can see the tiny structures of microvessels. Let's say in the winter, when the snow lay on the branches of the tree, the shiny from the snow can describe the small branches of the tree very clearly. So that's all for today. Thank you for your attention.
Thank you so much.